Good evening, everybody. Welcome to Med School Tutors Acid-Based Cases for the USMLE Step 1 and Step 2 webinar. This evening, we're going to focus primarily on talking about any and all acid-based questions you guys can see on your STEP exams. My name is Dr. Joe Hansen. I've been working with Med School Tutors as an individual tutor for the board exams for the last 4 or so years. In that time frame, I've worked with hundreds of students for thousands of hours online like this, teaching individual students how to prepare for these exams. I'm hoping to start to leverage some of that knowledge and experience that I have to help you guys this evening to learn how best to prepare for these types of questions on these exams. I'm joined by Dr. Moses Murdoch. Moses, you want to go ahead and introduce yourself a little bit?
Good evening, everyone. Thank you so much for joining us. Like Joe said, my name is Moses. I am also a senior USMLE tutor with Med School Tutors, have enjoyed spending time with students, helping them grasp these materials on a more intuitive level, and we're hoping to do that for you today. Very briefly, just to speak on who we are at MST, as Joe was alluding to, we are a group of students, residents, fellows, and attendings who have walked the path that you all are walking now. We have taken these exams. We've all done really well on those exams, often thanks to the mentorship and the advice from other people, and we're hoping to pass that along. The way we do that is primarily through one-on-one online tutoring, where we create personalized study schedules and study plans for you to achieve your goals. And that can be through all of the standardized exams in medical school and even beyond. As Joe was mentioning, he's had a ton of experience. Our core group has had a ton of experience working with a bunch of students. And I hope, as you'll see from the way we interact and the way we chat today, we really love this. We're a little bit nerdy, at least I am. I'll speak for myself. And we hope that that translates into an engaging and educational experience to you. If what we do here today, or if anything that I've said piques your interest, please go ahead and reach out to us. You can find the various ways to reach us at the bottom of the slide. We'll have more information at the end of the webinar, but please do reach out. Don't be shy. The path of medicine is a communal one, and we hope to be a part of that journey for you. Joe, how about you go over what we'll cover tonight?
Absolutely, pleasure to do so. And I will vouch that Moses is indeed a huge nerd, and we're lucky to have him because he really likes to talk about this stuff, and hopefully I can keep up with him this evening as we talk about acid-base abnormalities. So our priorities for tonight are to talk about why we care about this stuff in the first place, why it's important that we assess the acid-base status of our clinical patients, and how that's going to be important on the exam-based questions that you're going to see when you take your board exams. We'll orchestrate kind of a general framework and gestalt of how we should be approaching problems that include pH in them. And that means that we'll be approaching this from two major avenues, obviously from the acidosis side and from the alkalosis side. And then in order to better explain how we get respiratory alkalosis, respiratory acidosis, metabolic acidosis, metabolic alkalosis, we'll be going through some practice USMLE-style questions and giving you some tips and tricks as to how to very easily answer these questions when you see them. And then we'll wrap up by answering any questions that you guys might have about anything we talked about this evening. Now, along those lines, I'll emphasize as well, you might notice Moses or myself kind of glancing off to the side and maybe like looks like we're like thinking or something along those lines. We are going to be answering any questions that you guys have for us through the chat box that we have in Zoom here. And so if you guys ask us any questions throughout the course of our conversation, we'll do our best to address them directly, either in the conversation itself, or if it's a more directed question that we can answer more simply by typing, you might notice one of us kind of like gazing our attention off towards the side here. So apologies if it looks like we're being a little rude and kind of looking in another direction from time to time, but I do have another monitor where I'll try to answer any questions you have. So feel free to be communicative, reach out, talk to us as we're going through this. We're going to be asking you questions as well. We're going to try to be as kind of dynamic as we keep you guys interactive as possible. So with that being said, Moses, you want to lead us off by telling us why is acid-base stuff important?
Absolutely. So there's a very sort of technical answer to this that is rooted in the nitty-gritty of molecules and membranes. And then there's a very practical clinical implication for acid-base disorders. The big picture is that our body maintains homeostasis. We've probably all heard that word since middle school or high school biology classes. It basically means that for our bodies to function normally and healthily, it requires various parameters, electrolytes, temperature, and yes, pH, to be within a very narrow range. And the reason, if you zoom all the way in, is that the pH of the body and of the environment that bathes the cells is critical to protein conformation and to the proper establishment of electrochemical gradients that, if they become deranged, can have deleterious effects on cell biology, and that trickles up all the way through tissues, organs, and the entire organism. Clinically, I'm an internal medicine resident. I see this all the time. If if an acid-base disorder is present, that alarms me because it can often be the clue to something very serious that needs to be addressed expeditiously. So you see some of those examples on the slide. Sepsis, really dangerous bacterial infections, you can end up with a severe acidosis. DKA, where the body's ability to handle sugar is really deranged and can have profound hemodynamic and respiratory consequences, manifests, and one of the clues can be the ABG, the arterial blood gas. And of course, volume issues can impact the way the body handles pH, protons, and bicarb. So from all the way down to the protein, zoomed out all the way out to clinical problems that are frequently seen in real life, this is stuff that really matters. And for that reason, we're dedicating this webinar to it. And we'll kick off our discussion of how you can become comfortable dealing with these issues by talking about a general framework for how we think about pH. Joe, what's your framework for pH problems?
All right, let's jump into it. So first things first, we look at the pH, and the pH value that they're going to give you in the question is usually going to be somewhere around 7.4. That is the normal number when you're looking at questions on the exam. And when you look at the general reference lab values in UWorld or any question bank and maybe practice tests, you'll typically find that the pH can range in a healthy individual between 7.35 and 7.45, which means that Moses in his clinical experience is going to see patients that kind of bounce around the number 7.4. For the purposes of questions that you're going to see for step 1 and step 2, though, 7.4 is like the median number, which means that if we drift a little bit one direction or another, that usually means something. And so we're going to use that as our staple. The staple number is 7.4. And the first thing we want to know is, are we acidotic? Are we below that 7.4 value? Or are we alkalotic above that 7.4 value? Then we have to assess, is it a metabolic issue or is it a respiratory issue? And the way you're going to do that is you look at your 2 other cardinal values that we care about: the CO2 value and the bicarbonate value. CO2 controlled by the respiratory system. Therefore, if there's a respiratory problem, there's a problem with our CO2. For reference, the normal number there is 40. I recognize that lab values will tell you 35 to 45 millimeters of mercury is normally the normal range for CO2 and acceptable. 40 is the median number, and any deviation from that on these exams means that there's probably something happening there. Meanwhile, bicarbonate, entirely controlled by the metabolic system, which typically means kidneys specifically, but we're talking about every other organ as well, represents the amount of base in our body, and the number there is 24. Usually labs will say like 22 to 26. That one's a little bit weird, but generally speaking, 24 is the staple number, and anything above or below that is going to represent a change. So once you look at the pH and you identify that it is above or below 7.4, then you look to see what kind of changes do we have with bicarbonate, what kind of changes do we have with CO2. From there, we can determine what's the primary problem. If you see more CO2, that means you've got more acid. If you have less CO2, that means you have less acid and therefore are alkalotic. If your pH is alkalotic and your CO2 is in the alkalotic direction, that's probably your main issue. Alternatively, if bicarbonate seems to be aligning with the pH, you have more bicarb, more base, and the pH is greater than 7.5, alkalotic, it's probably primarily a metabolic issue. See which one of the 2 values, CO2 or bicarbonate, agrees with the directionality change that the pH gives you. From there, we assess what's going on the other side. So if you determine that it's a metabolic issue, then look at what the change is for the CO2. Is it compensating appropriately? Yes or no. Alternatively, if you find that you have a CO2 problem, do your best to see if there's a bicarbonate change that accommodates that as well. Finally, after you've determined the problem, then you can start doing the clinical thing. Is it diabetic ketoacidosis, or is it somebody who's repetitively vomiting? You can start to assess why they have the problem. And the important reason that we're going to figure that out, especially in step 2, is because the solution is always to treat the underlying diagnosis. We very, very rarely ever will directly try to tip the pH value in the patient directly, meaning that directly providing bicarbonate is almost never the correct answer on the exam, especially if your goal is merely to change the pH. Just fix the problem. The pH will be repaired after that. So to recap, look at the pH value, 7.4. Look at the CO2 value, 40. Look at the bicarbonate value, 24. See what direction they're going, see which ones align, and then from there, start to make your diagnosis. Anything to add to that, Moses?
That was beautifully stated. There was a question that came in through the chat that was asking how long it takes for things to compensate. And the truth is that there's some fuzziness around that. Let me emphasize that it's not immediate. So we're not talking on the order of minutes or an hour. Usually we're talking many hours into like maybe a couple of days. It depends on the underlying physiology, how healthy the underlying organs are. But if you're looking at something that's happened an hour ago or 30 minutes ago, that is not enough time for the body to appropriately compensate. The other little trick here is that our body's ability to modulate how fast we breathe is faster than our ability for the kidneys to hold on to bicarbonate or to change its transporters and how it deals with hydrochloric acid. So you can often see people change their breathing pretty fast. It takes a little bit longer for the kidneys to catch up. What have you seen in your experience on the test, Joe?
So as far as the exam goes, although the changes are not going to be immediate in real life when it comes to changing a respiratory rate necessarily, there is virtually no circumstance where there has not been enough time for respiratory compensation. On the exam, for all intents and purposes, respiratory compensation is functionally immediate because it does not take nearly as long as metabolic compensation, which means if we ever find that the CO2 value is not doing what we expect it to in terms of compensation, that is fundamentally a problem, capital P problem. There's something wrong with the breathing in this person. Meanwhile, as far as the metabolic changes go, we're usually expecting a time range of like 2 to 4 days or so on the exam, but for all intents and purposes, that makes it very difficult for us to determine, are we not compensating or has it just not been enough time for us to compensate? Meaning, is there a literal capital P problem happening, or do we just have to wait a little while for the kidneys and the metabolic system to catch up? So to summarize, on the exam, respiratory compensation should be more or less immediate, whereas metabolic compensation is usually on the order of days. And so commonly they will merely ask you, is this person compensating, yes or no? And the reason for failing to compensate is often just inadequate time.
Awesome. All right, so this is just a graphical representation of everything that Joe was talking about. The first level of analysis is just look at your pH. 7.4 is your standard, that is a normal pH. If it's less than 7.4, you are in acidemia land. If it's greater than 7.4, you are in alkalemia land. And after that, you're trying to determine, is the primary process driving this acid-base disorder a problem with the CO2? In other words, is it respiratory, or is it a problem with handling of bicarbonate, which would make it metabolic? And on the right, you just have a table, which I know makes people's head spins when the arrows are up, down, and you can't tell what's what. But all it's doing is it's summarizing the 4 big buckets, right? You can almost think of it like a 2x2 table. You're either in metabolic acidosis, metabolic alkalosis, or you're in the respiratory world. Respiratory acidosis, respiratory alkalosis. The third column there shows what the primary problem is. In every case, if it's respiratory, it's a CO2 problem. If it's metabolic, it's a bicarb problem. And then on the far right column, you see what we expect the body to do. In other words, the body doesn't like when the pH drifts from normal, and it will marshal the other organ system to try to correct the problem. So just as an example, if you have a metabolic acidosis, that means your bicarb is low. Your body will then strive to get rid of acid using the other system. In other words, using the respiratory system. Therefore, you expect the body to try to expel extra CO2 to bring the body back into a normal range in terms of the acid-base status. And you can run a similar analysis for each of the different types of pH problems. It'll marshal the opposite system to try to correct the underlying problem. And I'll just briefly mention, since this is linked, that one of the central formulas that guides all of this is the fact you might wonder, like, how does CO2, it's not charged, how does CO2 help manage metabolic acid-base problems? And that's because there's an enzyme in the body that converts CO2 and water in sort of a reversible fashion with carbonic acid. So if you're getting rid of CO2, that means functionally you're pulling the reaction in that direction and you're eliminating a source of acid. Conversely, if for some reason you can't get rid of CO2 and it's building up, it'll push the reaction in the other direction, generating carbonic acid, generating a more acidotic state. All right, acidemia, let's dive in.
All right, sure. So to piggyback on what you had just said really quickly, I do want to emphasize, you'll hear me mention that CO2 is very commonly an acid. And the reason is just as Moses had just mentioned, we can turn carbon dioxide into carbonic acid basically at any point that we want because we have ready availability of carbonic anhydrase. In particular, there's tons of carbonic anhydrase inside red blood cells, which are omnipresent throughout our body, which means we can always turn CO2 into an acid. So for all intents and purposes, to me, CO2 is an acid because we can always push CO2 to turn into carbonic acid, which we absolutely will do if we have a lot more CO2 than we should. And so think of CO2 as a respiratory acid on the one side and bicarbonate as a metabolically controlled base on the other side. So we have our acid and we have our base, and we can pull each lever independently of one another in order to fix whatever the underlying problem is. Focusing on acidemia first, which means our pH is less than 7.4. Notice we say 7.4 here just because the exam very classically will have 7.4 as the median value. I recognize that technically a pH of 7.37 is normal. Nevertheless, on the exam, that usually means very mild acidosis if you see that number. In particular, because bicarbonate is a base, if we have less bicarbonate, we have less base, we have acidosis. On the other hand, CO2 is an acid, so to speak, which means that if we have more CO2, we have more acid. In either circumstance, then we have a primary acidosis, either less bicarb to begin with or more CO2. So when we see a pH that is low, we want to see which one of those two things is true, because at least one of them must be true in order for us to have acidosis. After you identify acidosis, specifically with metabolic acidosis, you always have to calculate anion gap. And the reason we have to do that is that it's absolutely necessary in order to determine the diagnosis. There are causes of anion gap acidosis and causes of non-anion gap acidosis. So I'm going to ask you guys a really tough question here to kind of start us out. If we're looking at an anion gap acidosis, can you guys in the chat box type to us, what is the reason that it's an anion gap acidosis specifically? What makes it anion gap as opposed to non-anion gap? So special prizes to anybody who can answer this. Go ahead and send them to us in the chat box here. We already got one answer, which is excellent. Keep them coming, please. Good. All right. Cool. Excellent. Beautiful. Excellent. Great answers so far, guys. I really appreciate that because this was a hard question to start with. Anion gap means that we're producing a new acid. Now we can calculate that by doing this equation to prove that there is a new acid, but the idea is that there are extra unmeasured anions in the blood, and unmeasured anions would be what you have left behind after a hydrogen ion leaves an acid. That's what makes an acid, the production of a hydrogen ion that can freely dissociate from it. And the strength of the acid is the relative proclivity for that hydrogen to leave. So if you have a hydrogen leave a substance, that leaves behind an anion. And our laboratory results can't really measure that because we're not looking for lactate or ketone bodies or whatever. And so on our labs, we are left with a gap between positives and negatives. The idea being that any kind of new anion gap acidosis is going to be new acid. The alternative to that for a metabolic acidosis would be losing base. If I were like urinating out my bicarb, I wouldn't have more acid in my body. I just have less base in that case. So either way, we're going to have acidosis, but loss of bicarb, loss of base is going to be non-anion gap, and gaining a new acid of some sort is gaining it. So we're going to calculate that every time we have metabolic acidosis only. And that's the only circumstance where we calculate our anion gap. That's the first thing we look at for the metabolic side. On the respiratory side, we're going to start thinking about diagnosis there as well. If we have a respiratory acidosis, it means we have more acid, more CO2. And the one key thing you need to know about CO2 is that it is directly inversely correlated with our minute ventilation, which is how much air we're breathing. And the way we usually calculate that shorthand is to say respiratory rate. The faster somebody breathes, the more CO2 they eliminate. The slower they breathe, the more CO2 they accumulate. So you can read somebody who has a high CO2 explicitly meaning they're not breathing enough. So then if you see somebody who's developing a high CO2 on the exam, you should ask, why aren't they breathing enough? And that could be outright asphyxiation as one possibility. Many questions, though, will emphasize somebody who's coming in who's got an opioid overdose or some kind of sedative that's diminishing their respiratory drive as their primary problem. So takeaway here is either you have less bicarbonate, which can be anion gap or non-anion gap metabolic acidosis, or you can have more CO2 as a respiratory acidosis, in which case you probably have somebody who's hypoventilating and you should probably identify why or just intubate them right now. Anything to add to the basic acidosis stuff, Moses?
That was wonderful. In the slides to come, we'll drill into this a little bit, and we'll start with that really excellent discussion of anion gap metabolic acidosis. On the screen, you'll see a schema that comes from the clinical problem solvers. I'm sure you all have heard mud piles or gold mark as ways to remember the mnemonics, to remember which diagnoses and which substances can contribute to an anion gap metabolic acidosis. I really like this way of thinking about it because it emphasizes what you all were putting in the chat, that there is some unmeasured substance that is contributing to the anion gap that we're not measuring. And that substance could be something that the body is producing. You see that on the left side, like a lactic acid dissociates into lactate and a proton. So the proton contributes to the acidosis, and the lactate is what expands that anion gap, right? And you can do that with ketones, you can do that with sulfates and phosphates, etc. On the other hand, you can have exogenous sources that dissociate into a proton and a negatively charged sort of weak base to the strong acid that contributes to the anion gap. The key ones to remember are any of your toxic alcohols, right? And then you have the other ones that are highly tested, like salicylates, classic cause of an anion gap metabolic acidosis. And then you see there's a bunch of other medications largely that fall into that other category. And right in the middle, you see exactly what Joe was saying. The key principle here to emphasize is that in the body, you have to have electrical neutrality, right? The number of positive charges has got to equal the number of negative charges. But when we go draw a patient's blood and measure the anions, we're not measuring every possible charged species in that sample. We select ones that we have decided are clinically relevant. On the positive side, it's largely sodium, far and away sodium. And that's why potassium isn't really part of the calculation for anion gap. We sort of ignore it, but it's sodium and it's potassium. And then on the negative side, there's bicarb, chloride, and then everything else. And everything else falls into that anion gap, and it includes largely things like albumin. Now, if you think about it, if your bicarb goes down, we're talking about a metabolic acidosis, either the source of the acid was loss of bicarb, which is roughly equivalent to gain of hydrochloric acid, which means that you have a proton, that's the acidosis, and then you have chloride that has gone up. And that balances out such that the anion gap doesn't change. In contrast, you have an anion gap, which is what is on the screen now, which is where you have decreased the bicarb, and what makes up that space on the negative side of that ledger is the unmeasured things represented by the anion gap. All right, enough about gaps. Really important. Remember the big buckets and the diagnoses. The clinical vignette will also help you understand which of the, what seems like 10 to 15 different diagnoses you could have with an anion gap metabolic acidosis. Anything to add there, Joe, before we move on?
Let's go ahead and move on because I'm going to elaborate on this a little bit based on some questions that we've gotten from students. Thanks for asking questions, guys. One question in particular that somebody asked is, do we need to memorize the mnemonics that we had just discussed? The short answer is yes, Memorizing a mnemonic for anion gap acidosis is actually crucially important because there will be plenty of questions on the exam where you only see that they have an anion gap without really too many clinical indicators that definitively give you a diagnosis. And then your answer choices will include 4 not anion gap acidoses and 1 or 2 anion gap acidoses, which means if you know the mnemonic, then you can immediately cut out every answer that's not anion gap when you find an anion gap acidosis in the question stem. So takeaway is memorizing anion gap is super high yield. It turns out that memorizing non-anion gap acidosis is actually relatively not fruitful on the exam. It's probably not going to help you too much. So at the very least, memorize a mnemonic for anion gap. Mud piles is my favorite. That's the old school one. That's the one that I would suggest. Along those lines, calculating our anion gap, discussing what an anion gap means. So just to elaborate on what I had said before, because I got a couple questions about like, well, okay, wait, what are the 2 different types of metabolic acidosis? As Moses said, when we look at our anion gap, we look at the sodium value as all of the positive charges in our blood. There are other positive charges, but for all intents and purposes, sodium's like the big fish. There's like 140 for sodium and like 3 for potassium. So let's just round it down to sodium. That's all positive charges. There has to be a negative charge that pairs with that. When you look at your routine labs, though, the only negative charges that we usually get on routine labs are bicarb and chloride. We get like sodium, potassium, bicarb, chloride, BU, and creatinine. It's like our normal basic metabolic panel. The problem here is that chloride and bicarb are the only negative charges you see on labs, and sodium is the only positive charge that we care about. But there's always more sodium than the negatives. And that can't be because there has to be electrical equality in our bloodstream. We don't have more positives than negatives. So we have to conclude that the labs are incomplete, that we have not actually measured all of the negative charges merely by looking at bicarbonate and chloride. There's other stuff floating around. That's normal. You're supposed to have an anion gap because you have a little bit of phosphate, sulfate, lactate, ketones, citrate floating around your bloodstream. Now, though, if somebody develops a new acidosis, let's use lactic acid as an example down here. Lactic acid dissociates into a lactate anion and a hydrogen proton. The purpose of bicarbonate in our blood is to buffer our blood. If extra hydrogens are produced, bicarbonate is supposed to come in, snag those hydrogens, and get rid of them for us. So as our blood becomes more acidic, the bicarb comes in and basically destroys the hydrogen at a cost to itself. It turns into carbonic acid, then into CO2, and then we breathe it off. So the more lactate we accrue in our bloodstream, the less bicarbonate we get. By definition, lower bicarbonate means metabolic acidosis. And as the bicarb lowers, something replaces that negative charge. That something is the lactate anion. And as lactate replaces the bicarbonate, we find that the number of unmeasured anions in our blood increases. I'm not measuring lactate with my routine labs. So if I measured this person's blood when they're in lactic acidosis, I'd find that they have relatively low bicarb, normal chloride, and a big anion gap in that case. And this will hold true for any new acid that enters the body, whether we ingest it, like aspirin toxicity, or whether it's produced, like ketone bodies or lactate. Therefore, any kind of new acid in the body means anion gap. The easiest way to remember that is mud piles. On the other hand, a non-anion gap acidosis would mean less bicarbonate by definition, but less bicarbonate because we lost the bicarbonate, it fell out of our body, which means we replace the bicarb with whatever we can grab, which happens to be chloride. We retain chloride in our body. We prevent the loss of urinary chloride if our bicarb goes down on its own. And so we have a hyperchloremic metabolic acidosis when we have a non-anion gap. So simple takeaway, any new acid, anion gap. Any lack of base, which is technically different, that's non-anion gap. Hopefully that covers it pretty well. Just to elaborate, you can see the difference in like our graphs on the right there compared to what we had talked about before. And the mnemonic I like best here is mud piles. This is the one that I would always use on the exam. I'll point out that the highest yield ones that we can expect to see are probably going to be methanol, ethylene glycol, diabetic ketoacidosis, and aspirin toxicity. Those are the big ones that are likely to show up. Can't really say I've seen too many questions about like propylene glycol, paraldehyde, or even uremia for that matter. Occasionally isoniazid and iron show up from time to time, but this is the mnemonic that I'd encourage you to know. And I'll point out that the range that they have for anion gap on here, which I've stolen from UWorld, which is the most common Q bank to use, is going to end up being 10 to 14. But if you look at the range in first aid, they say the range is like 8 to 12. it's not going to matter on the exam. The anion gap will be way higher than 14 if they want you to know that it's an elevated anion gap. So we don't have to worry about specifying which range to utilize. Okay, I think that covers that. Good, thank you. Moving us to the other slide we had here. So the takeaway here then is that if we have a normal anion gap acidosis, we have to conclude that somehow we are losing bicarbonate. Now, this is where things get kind of complicated. On the one hand, we could be losing bicarbonate because we are losing bicarb in the urine. A really good example of that is utilizing acetazolamide, which is a medication that we can use as an osmotic diuretic, where we prevent ourselves from retaining bicarbonate in our urine or from our urine, so it just gets lost with our normal urinary production. That's the easiest way to think of a non-anion gap. Consider, on the other hand, that we could also be losing a lot of bicarbonate in our stool in somebody who has diarrhea, which is also sometimes called hyperalimentation on some of the diagrams you'll end up seeing. And so on the left side of our graph, what we're going to find is that we have loss of bicarbonate either in the stool or the urine. It's just like fallen out of our body in that case. And in that case, we have less bicarbonate, not because I accumulated a new acid of any sort, but because the bicarb just kind of tumbled out of me for some reason, whether it was a drug or diarrhea or something else. On the other hand, I want to point out that you're going to find that in certain circumstances, we're not going to be able to produce bicarbonate. We usually build bicarbonate in our body in the kidney. And the way we do that is we take CO2, add it to water, make carbonic acid, and then take the hydrogen and toss it into the urine. If you can toss the hydrogen into the urine from carbonic acid, you retain the bicarbonate. And so the idea is our kidney, specifically the collecting tubule, makes bicarbonate. And so as a result, if we find that we are unable to make bicarbonate in the kidney, which is to say we're unable to excrete acid, which also could mean we're unable to put titratable acids into the urine, which is on the right side of our diagram here, what we're going to find is that we are also unable to have enough bicarbonate because of a lack of synthesis. So bicarbonate can be diminished in our body because we don't build it in the first place, which means we are not excreting acid in the urine. Or alternatively, we are going to just lose bicarbonate from our body, which could also happen in the urine, but could also happen in the stool as well. I'll point out some of these are a little confusing. You'll notice on the right side of our diagram here, hypoaldosteronism is listed as a cause of inability to secrete acid. And it's important to point out that aldosterone is a really important hormone here. It tells the collecting tubule to make bicarbonate and dump acid in the urine. And so it turns out that you can have an endocrine reason for developing one of these non-anion gap metabolic acidoses. With all that being said, Moses, anything to add to our anion gap versus non-anion gap description here?
I think that was really great. Taking a step back, I think that there's GI causes and there's renal causes, and the renal causes are either intrinsically because something's going on in the kidney, or the endocrine system is sort of messed up and it's sending signals or mixed signals to the kidney. For instance, hypoaldosteronism, sometimes drugs can do this, like spironolactone. It messes with the RAS system and can lead to both potassium and acid issues. But no, that was beautifully described. This is just another, I'll quickly just run through this. Exactly as you were saying, Joe, if you have a non-anion gap metabolic acidosis, it's hyperchloremic, you're losing that bicarb, you're retaining what you can to keep that ledger between the positives and negatives even, and that's a hyperchloremic state. There is, of course, as in everything, mnemonic to remember all of these, but as Joe was saying, these are less useful, I would say, than mud piles or Goldmark, for instance. So that was a whirlwind tour of the acidosis from a metabolic standpoint. I'll briefly just talk about respiratory acidosis. And as Joe was alluding to, this is primarily a problem of getting rid of CO2. In other words, I've taken on this slide, we've broken up the total ventilation equation down to it's either a respiratory rate problem or a tidal volume problem, and it's more commonly a respiratory rate problem. And if you can't get rid of CO2, the classic teaching that you hear on the wards is you either can't breathe or you won't breathe. And there's a long list of things that can cause you to retain CO2 because you're not ventilating sufficiently. And I like to think about it, how does a normal human body initiate a breath, right? So you have something in your nervous system that is triggered, often, spoiler alert, by CO2, that says, hey, it's time to breathe. And if there's a problem with that system, then you might end up retaining CO2. And that could be something as simple as central, like instead of obstructive sleep apnea, it might be something like central sleep apnea. It could be a neurological injury of some sort in the area that controls ventilation. If you go down, that signal has to reach the diaphragm and the whole sort of thoracic apparatus that generates that negative pressure to initiate and sustain a breath. And if either you have sort of too much tissue, or you have a broken rib, or there's some muscular or nerve problem that's paralyzing your ability to take a breath, then you could end up with too much CO2. Um, the nervous system could be fine, the muscles could be fine, the thorax could be fine in its anatomic structure, but if there's asphyxiation, an upper airway problem, or if you have a pulmonary process, classically here, you would have like COPD that's really, really bad, or asthma that's really, really bad. So something that's obstructing the flow of air. And then occasionally, less likely, and I wouldn't spend too much thinking about this, but various other pulmonary alveolar processes can lead to retention of CO2 because you can't exchange gases as appropriately. So big picture here, you're retaining CO2. It's either because you can't breathe or you won't breathe, right? It's either a sedative, a neurologic injury, sleep apnea, or some obstructive process that's preventing you from ventilating appropriately. How about metabolic alkalosis, Joe?
All right, so metabolic alkalosis basically means that we have more bicarbonate. And so the question would be, where do we get that more bicarbonate from? Why do we have more bicarbonate? One example would be that we have somebody who has way too much aldosterone signaling. I mentioned a moment ago that aldosterone directly stimulates the collecting tubule to dump acid in the urine, thereby synthesizing, building, producing new bicarbonate for the body. And this is one of the only places that we can actually synthesize new bicarb. If you think about it, making bicarb means making carbonic acid, which is hydrogen and bicarb, which are just going to recombine back together anywhere that you make them through equilibrium, which means that you can never really just make a lone bicarb unless you can get rid of its hydrogen dancing partner. And the way that you do that is by dumping it in the urine. So the kidneys are really good at making bicarbonate, and they're going to do it under the influence of aldosterone, which helps to stimulate excretion of acid at the level of the collecting tubule, which means if somebody has hyperaldosteronism, they're just going to make too much bicarb. And so as a result, regardless of whether it's primary or secondary hyperaldosteronism, we're going to end up, and that means either the adrenal cortex is overproducing aldosterone on its own, or it's being told to do so because of renin release from the kidney. One way or the other, we're going to have metabolic alkalosis and too much synthesis of bicarbonate. On the other hand, we can find that somebody might just be volume depleted. Now, in that case, they will be making renin appropriately. They'd be making aldosterone appropriately. And as a result, they'd be making a lot more bicarb. So the idea here is like, why am I making way too much bicarb? Either I can be volume expanded because I have hyperaldosteronism, or I can be volume depleted, which then leads to the development of more aldosterone. I will point this out too, which is kind of important. The only other place in the body where I can really synthesize bicarb would be the stomach, because in order to make gastric acid, we're going to dump hydrogens into the stomach, and we have to get those hydrogens from somewhere. We get them from carbonic acid. It's the one acid we use everywhere. But when I make the hydrogens and put them into the stomach, they leave behind their bicarbonate dancing partner. Now, this is the mechanism behind an alkaline tide. When you eat a big meal, you might notice that somebody's pH in their blood might end up going up a little bit, alkalotic, while their gastric pH goes down. Of course, this is undone when we dump bicarbonate out from the pancreas into the intestines, getting rid of the extra bicarbonate from the body in a way, and then also neutralizing the gastric acid. Well, consider this for a second. What if we just started vomiting uncontrollably? All of the hydrogen in our stomach would exit into the environment. But to make that hydrogen, I also had to make bicarb, which is now stuck in the body. And in that way, the stomach can act a lot like the kidneys as a factory for building bicarbonate if you vomit out all of your hydrochloric acid. So vomiting is a cause of metabolic alkalosis. And it's going to be reinforced by the fact that if you're vomiting, you're also hypovolemic, and therefore your kidneys get mad and they release renin, which leads to more aldosterone release, which then leads to more bicarbonate synthesis in the kidney as well. So you get kind of a 2-for-1 when it comes to repetitive vomiting. Now, one thing that you might be asked on the exam, which is a little tricky, is that you have a patient who's coming in and you can see based on their ABG that they have metabolic alkalosis, a high bicarbonate, but they are comatose. So if they're comatose, you can't ask them what's wrong. You can't ask them, have you been vomiting a lot? So can you guys tell me in the chat, what is the one test you would do to determine the etiology of metabolic alkalosis, to determine if, hey, is this vomiting causing this, if you can't just ask the patient? So what test are we looking for to determine the etiology of our metabolic alkalosis? Got a couple people typing in the chat. Very good. All right, keep them coming. So, all right, excellent. Again, testing to see, why do we have metabolic alkalosis? What is the thing that we can look for that can help us to determine that? See if we can get two more people to throw an answer at us here. So we got a couple good correct answers here. As you can see on the bottom left of this slide, it's the urine chloride. If we were losing bicarbonate in the intestine, if we're losing bicarbonate by, or excuse me, let me restate that. If I'm losing acid by vomiting, if I'm dumping out my acid by vomiting, I'm losing chloride with that, which means that I am not going to end up having a lot of chloride in my urine. However, on the other hand, if I'm building a lot of new bicarbonate in the kidneys to bring a bicarb into the body to make a new bicarb de novo, I've got to get rid of another negative charge to make room for that bicarbonate. And so I'm going to have high urinary chloride if it's the kidneys that are responsible. So the takeaway here is that if you are removing gastric contents and sucking hydrochloric acid out of the stomach with an NG tube, or they're vomiting, the chloride's going out this way. Chloride has to go down if we have more bicarb in our plasma. You gain one negative charge and you lose the other. So you can lose the chloride up, or you can lose the chloride down in the urine. So as soon as you see metabolic alkalosis, if the patient can't outright tell you or refuses to outright tell you that they've been vomiting repetitively, you can identify it by looking for the urinary chloride, which is an extra little trick that we can do to make that determination. Takeaway though is, somebody's got metabolic alkalosis, means they have high bicarb, and our question is, why? Did they make a lot of bicarb in the stomach because they're vomiting a lot? They make a lot of bicarb in the kidney, and was that under the influence of aldosterone specifically, whether primary or secondary? Anything to add to that, Moses?
That was great. I would just add, just so it doesn't confuse folks, on the right side of this graph, the PRA stands for plasmin renin activity, which just feeds back into this concept that the renin, aldosterone, angiotensin system is really important for controlling bicarb handling and therefore pH. I will just talk now about respiratory alkalosis. And in a sense, it's just the same conversation we had about respiratory acidosis, but flipping it on its head. It's a problem of eliminating too much CO2. And if we translate that, considering CO2 is our acid, it's getting rid of too much acid via the respiratory system. Again, a respiratory rate or tidal volume problem. So then you ask yourself, if I'm getting rid of too much CO2, I'm probably breathing too fast or taking too deep of a breath, probably more the former. Why is that? Sometimes it's as simple as an anxiety attack. Folks are anxious, they're breathing really, really fast, they're getting rid of too much CO2. Sometimes it's a problem with the lungs. You can have a pulmonary embolism, for instance. Folks feel short of breath, there's tachycardia, and there's also tachypnea, which will lead to a respiratory alkalosis. Heart failure, similar reasons. There's some pulmonary edema, folks are breathing fast. There's a common theme here, they're breathing fast. Aspirin we'll get to because it's complicated. I know that Joe put some descriptions in the chat. It's a tricky one because there's two things going on, right? Aspirin's effect on the respiratory center in the brain, and simultaneously its effect on the respiratory transport chain that leads both to a respiratory problem and a metabolic problem. I promise we'll get back to that. And then, of course, if as physicians, we are controlling someone's ventilatory status, we can generate a respiratory alkalosis if we don't set our parameters on mechanical ventilation correctly. I mean, just to complete that picture, it's possible also to get a respiratory acidosis through mechanical ventilation, although I didn't put that on the prior slide. Anything to add here on respiratory alkalosis, Joe?
No, excellently stated. All right, so let's go ahead and talk about compensation and how we should assess that. So now that we made the determination, is the bicarb high or low? Is the CO2 high or low? Which one of those is the driving force in our primary cause of some kind of acid or base problem? The next thing we got to do is look at the other one. So if we determine that we have a primary respiratory alkalosis, we got to go back and look at the metabolic side of the equation, the bicarb, to determine whether or not we have adequate compensation. Here's the real trick to this, though. The only one that really, really matters, that definitely will show up on your exam with high frequency, is the compensation for metabolic acidosis. I want you to consider this for a second. Imagine that you have a patient who's coming in and they've got diabetic ketoacidosis. So they're very acidotic. And as a result of that, they need to compensate by developing respiratory alkalosis. And the way that we're going to develop respiratory alkalosis, as I mentioned before, is by breathing fast. That's how you lower your CO2 value. So what you're going to find is that a patient who's in DKA will commonly exhibit a high respiratory rate and a high tidal volume, which we typically call Kussmaul's respirations, or breathing out tons of air, trying to blow off all that extra CO2 that they have, or rather all the extra acid they have, and lower their CO2 as much as possible. But imagine this, a patient is undergoing respiratory compensation. They are breathing very fast, very heavy. You can only do that for so long. And eventually the diaphragm will get tired. And eventually the patient will go into respiratory failure because they simply cannot breathe fast enough anymore because they fatigued their diaphragm. That is catastrophic. That is life-threatening, and you might need to literally intubate and mechanically ventilate that patient. They could be dying in that case. But on the other hand, consider this. What if we have somebody who's got metabolic alkalosis? So let's say somebody's vomiting repetitively. Well, how do I compensate for that? I retain CO2. I develop respiratory acidosis. And how do I retain CO2? I just stop breathing. Well, nothing can really stop me from stopping breathing, right? Like stopping breathing isn't going to be something that you cannot do under any circumstances. So there's no danger there, right? Like if we're not compensating on the respiratory side for metabolic alkalosis, that's not exactly a medical emergency in the same way that being unable to breathe would be a medical emergency. For that reason, what I'm getting at is if you look at the top two on our table here, metabolic acidosis, metabolic alkalosis, the compensatory change for those is wildly different in terms of importance. You need to know if somebody's compensating for metabolic acidosis, because if you identify they're not compensating, they could be hypoventilating, which is life-threatening. If they're not compensating for metabolic alkalosis, like, okay, like not really as big of a medical issue. For that reason, we have a very fancy formula to determine whether or not we have compensation for metabolic acidosis, which is Winter's formula. And what that is telling us is what should the CO2 be if we have acidosis. And if we fail to hit that mark, if our CO2 doesn't become that number, then that means that we have failed to compensate. And that formula is 1.5 times bicarb plus 8. And then you get a little wiggle factor of plus or minus 2 to give you a range of possible values. You must know that one, which means when you're looking at metabolic acidosis, you have two things that you must immediately calculate right away. The anion gap to determine whether it's anion gap or non-anion gap for etiology, and Winter's formula, supposing that they give you enough values to figure that stuff out. They need to give you the electrolytes to measure the anion gap. They need to give you the actual CO2 value to determine if their CO2 is within the range of Winter's formula. But you always are going to do those two calculations every time you're allowed to for metabolic acidosis. For metabolic alkalosis, it's probably not going to come up too much, but the general idea is that CO2 should go up for about 0.7 for every one of our bicarb. Meanwhile, if we're looking at respiratory acidosis and respiratory alkalosis, and the question of whether our kidneys are compensating, whether we have metabolic compensation, well, I can't tell because I don't know if this patient developed a problem 5 minutes ago or 5 days ago. And if they developed a problem 5 minutes ago, there's not enough time for compensation anyway. So these questions get really hard to ask on the exam because they can't really ask you whether they failed to compensate unless they explicitly tell you, hey, it's been 10 days, is this person compensating? Unless they explicitly tell you the duration of time has been a long time, it's usually a relatively acute process, in which case there's not enough time for compensation anyway. So doesn't really matter too much. And all you're really looking for is that bicarb's going in the right direction, generally speaking. The numbers you can use if you want to memorize these explicitly is 1 change in bicarb for every 10 in CO2 in respiratory acidosis, 2 changes in bicarb for every 10 changes in CO2 for respiratory alkalosis. Not really that important overall, though. If there's one thing that you got to memorize, you got to memorize Fenner's formula. You're going to do that whenever you do your anion gap calculation as well. So I think we've walked through like our diagnosis and our compensation assessment. Anything to add to that, Moses, before some sample questions?
I think we're ready to dive right in.
Cool.
So folks, here is where we really want you to continue being interactive. I'll read the question, give you all a chance to think, and then I'll pose a series of questions to help lead us to the right answer. So here we have a 5-year-old boy brought to the emergency room 12 hours after he was found next to an open pill bottle. There's some key symptomatology here: nausea, dizziness, and a quote, bee buzzing in his ears. The boy states he ate numerous pills because he thought they were candy. So he has a fever, he's tachycardic, he's tachypnic, and appears confused. And they're presenting us with the classic triad of values from blood gas analysis. And they're asking us which one of these would be most consistent with this diagnosis and the clinical picture they're presenting. Okay, so first of all, it's important to establish a diagnosis. So in the chat, what do you think was in the pill bottle? Go ahead and put it in the chat. Thank you so much for being so interactive. Yes, so this is a salicylate, right? Aspirin, perfect. And I'll just point out the key things that point in that direction. One, the tinnitus. That's pretty classic for aspirin, right? And then we have the hemodynamic profile, the breathing pretty fast, which will tie in directly to our pH, CO2, and bicarb analysis. So now we've been sort of foreshadowing this question throughout the webinar. There are 2 problems that occur with salicylate overdose. In the chat, go ahead and put what you think those 2 pH problems are. And you're picking 2 out of the 4, right? It's either respiratory acidosis or alkalosis, metabolic acidosis or alkalosis. It's 2 of those 4. Which do we see? I'll give you all a few moments to pop that into the chat. And I'm seeing lots of right answers. And what's key is that we're picking one, so to speak, from each bucket. Y'all are doing great. So it's a respiratory alkalosis plus a metabolic acidosis. So now, what do we expect the pH to be? Is it more acidosis or more alkalosis or somewhere in the middle? What do you all think? In these, it's tough to tell because you have 2 separate processes going on. Classically for the exam, the pH will be close to normal because the metabolic acidosis is, and I don't want to use the word compensating because that's not exactly what's going on here. So it is in parallel with a respiratory alkalosis. So now if we look at these panels, let's ignore the pH for a while, although I sort of gave you away the answer there. In a respiratory alkalosis, we would expect the CO2 to be low, right? Because it's alkalosis, you're getting rid of CO2. So that means if 40 is our reference value, we can get rid of D already. And if we are looking at the metabolic acidosis, I expect the plasma bicarb to also be low, right? Because it's a metabolic acidosis. So just like folks are saying in the chat, less than 24. So with those 2 combos, we expect the pH to be close-ish to normal. We expect the CO2 to be low and the bicarb to be low. That means that we get rid of E because the pH is just fragrantly alkalotic. D because we expect the CO2 to be low. C, the pH is fine, but the CO2 is normal. And we already said that there's a respiratory problem. This is pretty much a normal ABG, more or less, with a little bit of wiggle room. B sort of fits the bill because pH is closest to 7.4. The CO2 is low, that's the respiratory alkalosis. And the bicarb is also low, that's the metabolic acidosis. So I'm thinking B is the right answer. A is already, I'm suspicious it's not right because the pH is a little low for what I think is going on. I would expect the CO2 to be low, and it's not, it's just mildly low. And the plasma bicarb is close. So the best answer here is B. Now, this is a question that comes up constantly, and I'm seeing it in the chat too. The timing, and it goes back to what Joe said. Here, we've had 12 hours, right? And this is around the time where we would expect both processes to be going on at the same time. Here's the sneak peek though. When test writers test aspirin, this aspirin toxicity leading to pH problems, this is what they test. They test both happening at the same time, the overwhelming amount of the time. Joe, anything to add? Anything I missed in the chat?
No, I'll point out that the chat response that I gave was to an individual student, so I want to elaborate on that a little bit because I don't think everybody saw it, and I'll go ahead and type it to everybody in just a moment here. As Moses had indicated, for the purpose of the exam, the timeline that we're looking at is almost always, and I'll be a little controversial and say virtually always on the exam, an overlap between both processes. Typically, we're going to find that when we look at what they say in like first aid and they discuss like, the timeline of respiratory alkalosis, metabolic acidosis, the respiratory component happens first, the metabolic component happens later, but there's going to be a period of overlap. And virtually every question they're ever going to ask on the exam about aspirin toxicity, and we're talking like step 1 all the way up through step 2 in clinical shelf exams, is going to describe both happening simultaneously because they're almost always going to talk about the overlap period. And so the unique thing about aspirin toxicity is it's the one time that you have two primary processes happening at the same time. You have alkalosis on one end, acidosis on the other. So there is no compensation that's happening. It's just two opposing problems that yield a normal pH, which should never happen. Virtually any acid-base problem you ever encounter will have a pH that tilts one direction or the other, because no matter what the compensatory mechanism is that we use, we never go back to normal. An example that I like to use to describe that is, imagine you have a patient who is hemorrhaging. Their blood pressure will be low. They will be trying to raise their blood pressure by increasing their heart rate, by increasing vasoconstriction and vascular resistance. But you don't expect the person who's hemorrhaging to have a normal blood pressure. Similarly, you would not anticipate that a patient in metabolic acidosis would have a normal pH because we compensated enough. Compensation never gets you back to normal. So because we're arguing here that the pH is very close to normal in aspirin toxicity, well, that's because you have two completely opposite problems that are canceling each other out, not because we have super good compensation, because such a thing doesn't exist. I think that kind of covers like the questions that students had here, but I want to elaborate on one thing. If you take a look at our next slide, a pet peeve of mine is people describing aspirin toxicity as causing a fever, because fever technically means that we have changed our set point to raise our body temperature by altering our hypothalamus, usually through using, test question, interleukin 1, interleukin 6, and tumor necrosis factor. Those are the big guys that are going to be causing a fever by changing our set point. But you might ask, well, that's weird because you just said that aspirin causes a fever or raises our body temperature. And I'm kind of confused by that because aspirin's an antipyretic. It's supposed to like cause our fever to go away, right? Like that's how like NSAIDs might work, and that's how aspirin works, by inhibiting the production of, or inhibiting the effect of cyclooxygenase and inhibiting the production of prostaglandins. So you're correct that aspirin is supposed to cancel a fever, not cause a fever. And the reason I brought up this lovely picture of our electron transport chain is to say that aspirin causes decoupling of the electron transport chain. If you overdose on aspirin, you break the electron transport chain so that it releases hydrogens. It undoes the hydrogen gradients that we produced here. The problem is, instead of capturing energy as chemical energy as ATP, the energy just kind of like bleeds off as waste, and waste energy is heat. So the thing that happens with aspirin toxicity is that we primarily overheat. This is the same mechanism, by the way, that brown fat utilizes. So like when a bear is hibernating in a cave, they're real good at turning their fat energy into heat by uncoupling their electron transport chain in certain cells. We're pretty bad at that. Generally speaking, humans don't really have a lot of brown fat. Babies have a little bit more than adults. But generally speaking, aspirin toxicity causes this decoupling and overheating. So I just want to emphasize that so you guys don't forget it. If you see a fever, you're like, oh no, but aspirin can't cause a fever. It cancels a fever. You're right. It doesn't cause a fever. It causes overheating or hyperthermia. Anything to add to that, Moses?
No, I would just say that there's a question that came through that asked about the O2 level and when that's useful. So in clinical practice, the PaO2 is an excellent and very important value that we get. For the purposes of pH analysis, we leave that aside because it's not as relevant. Because remember, CO2 is the key molecule for pH. The O2 we get when we're trying to figure out what type of respiratory failure are they in. Is it primarily hypercarbic or is it hypoxemic? Are we doing okay when we're ventilating a patient? Do we need to send someone to the ICU? What is their PF ratio? Do they have ARDS? This is outside the scope of this webinar, but for the purposes of pH, really the thing you're looking at is the CO2 and the bicarb. All right, I think, Joe, that you are up for the next question.
All right, let's do it. So starting from the top, we have a 40-year-old female nurse brought to the ED for confusion and lethargy. Her temperature is normal, 38.6 or 98 Fahrenheit. Her blood pressure is 85/45. Her pulse is 125, and her respirations are 13. I'll point out that this is a low blood pressure and a fast pulse. I might start thinking about different types of shock in this case, of which there are 4 types, which we'll talk about in a bit. Rapid ABG shows a pH of 7.6, a PCO2 of 50, and a PO2 of 86, which is relevant to the question we just got asked about whether oxygen matters too much. They want to know which of the following laboratory tests would be most useful in diagnosing the cause of this patient's acid-base abnormality. So the first thing we have to do is determine what is the problem. So the pH is 7.6, and I'll throw out there that means that we are alkalotic. Given that the CO2 is 50, and that they didn't tell me the bicarbonate value, which is a little curious here. What is the primary disorder in the chat? If you guys can go ahead and type to us, what do you think? We don't have all 3 values, but we can probably still figure out what's happening. So what's our primary disorder here? A couple good answers coming in. Okay, all right. Excellent. So we got some variety in our answers here. One thing I'll point out is that if we see the pH is 7.6, we know that they are, by definition, alkalotic. So the primary problem has to be alkalosis. The primary problem cannot be acidosis. But I know that CO2 is a respiratory acid, and I see that the CO2 is higher than 40. I have more acid. So I have respiratory acidosis, but I know the problem is alkalosis. Well, I can conclude then that we must have metabolic alkalosis. That's the only explanation that could explain why the pH is so high. The pH should be low if CO2 had anything to say about it. So what I have to conclude then is that CO2 is desperately trying to bring our pH back down to 7.4, which means that the CO2 is the compensatory mechanism, and the hidden, unstated problem is that our bicarbonate value is likely in this case relatively high, causing metabolic alkalosis. So we talked about this earlier. This person has metabolic alkalosis and they are confused and lethargic. They're incapable of providing any kind of answer to what's happening. So, all right, people are jumping ahead, but go ahead and answer if you haven't yet. What do you think we should do? What's our answer choice for determining how this happened or to figure out the etiology? All right, lots of great answers. Everybody's saying D, urine chloride, and that is correct because we need to know, is this unconscious person developing alkalosis because they were vomiting out their acid, or was it because they were having an issue where they were urinating out acid? And so where was the bicarb made, the stomach or the kidneys? And the way you figure that out is by looking at urine chloride. If they are dumping chloride in the urine, this is like an aldosterone kidney problem. But if there's 0 chloride in the urine, I know if I have high bicarb, chloride had to go somewhere. If it ain't in the urine, it's probably in the emesis. And so therefore the urinary chloride can give us a very clear answer as to where our problem is. Cool. Excellent job. Thanks for participating, guys.
That was awesome.
Yeah, the only thing we have to add to that is just like bring up the diagram again that we used last time to show that if you find a person who looks like they're volume depleted, you then should look at their urine chloride to determine the issue. I'll simply mention, by the way, that a low blood pressure and a fast pulse, that's probably your volume depleted patient. That was the indicator that we used in that case to say that we should be on the left side of this diagram. And I'll just really quickly point out, anytime you see a low blood pressure and a fast pulse on the exam, start thinking we're looking at some type of shock. And the types of shock are hypovolemic, number one, but then also cardiogenic, obstructive, and distributive. So every time you see low blood pressure, start spinning those wheels. There's a really good diagram in the cardiac section talking about shock. I'd take a look at it afterwards. All right, that's my spiel on that. Moses, go ahead and take us away on the next one here.
Love it. Here we have a short little vignette, but it's actually really informative. So we have a 45-year-old man, unresponsive in the ED, and right off the bat, no more information. They just give us the blood gas. And it's 7.24, 70, and 25 for the bicarb. Most likely cause. So first, let's take this step by step in an organized fashion. What is the primary abnormality here? The primary abnormality. I'm going to wait a few more moments. Perfect. So we've identified that the pH is less than 7.4, which means we're an acid. And then we're looking, is the primary problem a CO2 problem making it respiratory or a bicarb problem making it metabolic? And here we see that the CO2 is very high. It is 70, okay? And the bicarb, it's pretty close to normal. Normal is 24. And here we have the cause. So let's just tick down the answer choices. COPD. Does it cause a respiratory acidosis? The answer is yes. Folks are already putting that in the chat. Wonderful. So that's a potential answer. DKA, yes or no? Does it cause a respiratory acidosis? No, the ketones, this is an anion gap metabolic acidosis, so we eliminate B. Diuretic abuse, does it cause a respiratory acidosis? You're right, no, we mentioned it can cause a different acid-base abnormality, but we wouldn't expect the CO2 to be 70 with a diuretic abuse. There, we're getting rid of volume, getting rid of chloride, hint, hint, prior question. And here we have a heroin overdose. Can that cause a respiratory acidosis? And folks are saying yes, yes, retaining CO2. And lastly, panic attack. Does that cause a respiratory acidosis? And most folks are saying no, because if you're breathing really quickly in a panic attack, actually get rid of CO2 and cause a respiratory alkalosis. So now we find ourselves in a little bit of a tricky spot because we have two answers that can lead to a respiratory acidosis. How do we pick between them? And someone in the chat is already getting the right answer here. Let's look at the bicarb. What do you expect the bicarb to do in a respiratory acidosis? So you're acidotic, your body's going to use the other system as we were discussing to compensate. You would expect it to go up, but in this case, it hasn't gone up. So really, and remember that as we were saying earlier, respiratory is really fast. For the purposes of the exam, the compensation is almost immediate. But the bicarb can take a little bit longer, but still, we think that this is, and put it in the chat, is this an acute process or a chronic process? From all the information we have, we suspect it's an acute problem. Therefore, D is the right answer, as folks are putting in the chat. Wonderful. So you see, this is a really short vignette, but it gets to the subtleties of what we expect the primary problem to be, and then the compensation. And in the real world, the compensation is something that happens over time. It's not a binary on-off switch, but for the purposes of the exam, use the clues that you have to either say, yes, this is appropriate compensation, no, it's not appropriate compensation. And in this case, the bicarb is stone cold normal, leading us to pick the acute process as the best answer in a multiple choice exam. All right, I think we only have one problem left. Joe, anything to add here, or should we dive into your problem?
No, excellently stated. Really well done. I guess I'll just really quickly point out, somebody had asked in the chat, why would COPD cause acidosis? Just to elaborate on that a little bit, Any kind of respiratory problem is going to make it so that it's harder to breathe, meaning that there's going to be less movement of air, less minute ventilation, which means that we're going to accumulate CO2. That counts for both restrictive and obstructive lung disease of any stripe. So any kind of chronic lung disease likely means that our minute ventilation is diminished, which would cause respiratory acidosis, probably chronic respiratory acidosis. With that, let's go ahead and pop into our last question, and it's kind of a doozy. There's a lot going on here, a lot to learn. So we'll do our best to quickly run through this. Stick with me for a few more minutes here. So here we have a 22-year-old man brought to the ED by his friend for confusion and progressive weakness. The friend says the patient has been drinking water all the time and going to the bathroom more since he had an upper respiratory tract infection 3 days ago. So polyuria, polydipsia. He has a temperature of 99.5 Fahrenheit, blood pressure of 95/55, which is low, a pulse of 115, which is high, and physical exam shows dry mucous membranes, and urinalysis reveals a strong fruity odor. In the chat, diagnosis. What do you guys think? What's our clinical diagnosis with polyuria, polydipsia, and fruity smelling urine? Okay, so what we've identified here, you guys are killing this one, is that we can identify the problem based on the clinical vignette in many cases. And then the lab values can, in some cases, be slightly redundant in terms of making the initial diagnosis. That being said, this is probably diabetic ketoacidosis. Great job, everybody. The ketones in the urine allow for acetone formation, and acetone's the fruity smell. Personally, I'm not really that keen on calling acetone a fruity smell. It doesn't really smell fruity to me personally, but that's what they say on the exam all the time at the very least. So if we're looking down at our laboratory values, the key labs that stand out are a bicarbonate value that is low, a pH value that is low, bicarb's less than 24, pH is less than 7.4, and a CO2 value that is pretty much exactly normal. So everybody tell me real quick, what's the primary acid-base problem? You kind of already know based on DKA, but humor me a little bit. What is the problem? Is this metabolic acidosis or respiratory acidosis, given that we have that low pH value? Good. All right. Everybody's on top of this one. This is most likely metabolic acidosis. And some people are even throwing in the extra bonus, which is that whenever we have metabolic acidosis, we should be calculating something, which is our anion gap. And if we do that here, that's sodium minus the combination of chloride and bicarb. Sodium is 135, chloride and bicarb are together 114, and the anion gap is 21 in this case, which is above 14, definitely high. And that is the D in mud piles, is diabetic ketoacidosis. So we kind of already knew it was going to be an anion gap acidosis. Not really too much of a surprise, one would think, if we already know the diagnosis there, but there we go, we've proven it. The glucose, by the way, is also 500, which is consistent with DKA. I think we got our diagnosis, but in the chat, can you guys tell me, what is the equation that we still have left to do? We already did anion gap, but there was a second one that we said that we always have to do every time we have metabolic acidosis. All right, great. You guys are super fast on these answers. You guys are killing this. So this question is going to be relatively easy for you then, which is surprising because this is one of the hardest ones that I've seen asked in clinical exams. So Winner's formula is the thing that we have to calculate because we need to determine whether or not this person is adequately compensating. So you guys have been answering all my questions perfectly. What is the Winner's formula calculation? Can you guys tell me the number that you get from calculating Winner's? I'm not even going to give you the equation. I'm going to ask you guys to remember back. What was the equation for Winner's formula? What number do you get? Give you a second to calculate this out. Ooh, all right, good answers, good answers. All right. You guys are giving me the range even, which is perfect. So Winner's formula is 1.5 times bicarb plus 8. Our bicarb is 14. So 1.5 times 14 is 21. And 21 plus 8 would be 29. Now there's a wiggle factor, plus or minus 2, which means 29 minus 2 is 27. 29 plus 2 is 31. Winner's formula gives you a range for CO2, 27 to 31. The CO2 is 40. What does that mean? If our CO2 is substantially higher than it's supposed to be, what else do we have in this patient? Good, good, excellent, awesome. There's two ways to say this. You guys are nailing both of them. You can either say that this person is not compensating, correct. I mean, one thing you could look at here is this person has diabetic ketoacidosis and their CO2 is 40. They should change a little bit, right? Like they should try to compensate because as we said before, On the exam, it should not take any time for respiratory compensation. So we can't make the case that this is too acute. Also, they said that this patient's been having problems for like 3 days. So like it's not an acute problem that we haven't adjusted for yet. We're not compensating because the CO2 hasn't changed at all. But also we're finding the CO2 is substantially higher than we want it to be. And that's the definition of respiratory acidosis. So we have a mixed respiratory and metabolic acidosis. Given that we found they have respiratory acidosis, which answer choice is probably happening in this patient? We got one good answer already. Go ahead and type in the chat. What do you think the answer to the question is? What is most likely occurring in this patient, given that I know they have respiratory acidosis on top of the immediately obvious DKA? All right, lots of good answers here. Excellent, excellent. Okay, good. Good answer based on what we said in the chat. So the answer is respiratory failure. And the reason that's respiratory failure is that we have a higher CO2 than we wanted to, and that means we're not breathing enough. And the reason that this is likely happening is that this patient has been doing Kussmaul respirations for the last 3 days, and his diaphragm is finally done with it and is going to give up. And now he's actually breathing exactly as much as Moses and myself might be breathing right now with a CO2 of 40, but he should be breathing faster than that. And I should be really concerned that if he's only breathing as fast as a healthy patient right now, he's very quickly going to breathe slower and slower and slower than this even. He's probably going to get to the point where he's not able to breathe at all unless we intervene by fixing the underlying problem or helping him to breathe with mechanical ventilation in this case. So takeaway is, every time you see a metabolic acidosis, do both the anion gap calculation and Winner's formula, because it will snag a question like this where respiratory failure might not have been very high on our list if we just said, oh, clinically it's diabetic ketoacidosis. Yes, but read into the equate or read into the laboratory values and use those to answer the actual question they're asking here, which is the extra thing on top of the DKA. Cool. Moses, anything to add to that?
I just really want to emphasize how important a normal value that isn't normal is, because it's very easy to get tricked and be like, oh, the CO2 is totally normal, and just glaze over it, not realizing that that's not where the patient should be. Their respiratory status should be they should be breathing really fast. And the fact that they're not is actually scary. And a picture like this clinically, this person's possibly on their way to getting intubated, to have us support their breathing to appropriately compensate for their DKA. This is one of the reasons why folks with DKA end up in the ICU. It's either because they're on an insulin drip or because their respiratory and pH status goes beyond what they're able to compensate for themselves. Little bonus point here, notice that the sodium is a little bit low, but that's a fake out because you have to correct the sodium for the glucose. So not relevant to pH, but it might come up in other questions. Don't be fooled by pseudo hyponatremia because of hyperglycemia. With that, I hope you all found that really useful. In summary, we went over the framework for pH, thinking about whether you're acidotic and alkaline or alkalemic, respiratory versus metabolic, the mnemonics, and some practice problems. I just want to return very briefly to talk about Blueprint MST and really emphasize that we are here for you, whether it's in a webinar or if what you heard today sounded like something you wanted to explore on a one-on-one basis. We are happy to chat with you, to explore what options are available for you, whether that be one-on-one tutoring, helping with schedules, helping with a content area that you've been struggling with, as well as some other sort of courses and planning sessions that are available. We really enjoy working with students. We love being part of your success. So if that sounds like something that you'd be interested in, please, please, please never worry alone. We are here for you. And with that, we would love to transition to any questions you might have, live Q&A. We'll do a couple of minutes. I recognize that time is precious and we've gone over our 1 hour, but are happy to answer any lingering questions that might be in the chat. So don't be shy, go ahead and put those in there. Joe, are you seeing anything right off the bat?
Yeah, we got some good ones. So somebody asked about the double delta. So anybody hearing about that and recognizing what that is, that's a bit of a scary one. The basic idea here is that no, I strongly suspect you will not run into the double delta on the board exams. It is a little too complicated for them to likely throw into a question, and I have not really encountered much that would suggest that that's likely to show up on the exam. I will simply state this. It is possible to have both a metabolic acidosis of the anion gap flavor and of the non-anion gap flavor at the same time. If you were to run into both of those, the bicarb would go down a whole lot and the anion gap would go up a little bit. So if you have very little bicarb and the anion gap only goes up a little bit, well, then the anion gap isn't responsible for all of the bicarb change. And that's what the double delta is saying. What's the change in your anion gap? What's the change in your bicarb? In diabetic ketoacidosis, those two things should be equal to each other. The anion gap increases as the bicarb falls. But if you had diabetic ketoacidosis, and for some reason you were using acetazolamide causing a non-anion gap acidosis, you'd be having a bigger change in bicarb than the anion gap change represents, and that's our double delta, simply stated. It is unlikely that you would ever need to calculate that on one of these exams, so you can safely save that for answering a tough question on the wards if somebody were to ask you that while you're on your medicine or pediatrics rotation, for instance. Moses, you see any questions in here that are really high yield that we didn't address here?
The only thing here is a question about diarrhea and the effects that can come from diarrhea. You can have bicarb loss through diarrhea. And so I would say that just like there's multiple sources in which you can get rid of bicarb. Diarrhea is one of them. Anything to add there, Joe?
No, I think you nailed it. Sounds good to me. One thing to add to another question that student asked is, well, if we do our Winner's formula and we see that the CO2 is higher than calculated, that's respiratory acidosis, right? Yes, it is a primary respiratory acidosis on top of the metabolic problem. But what if we had a CO2 that was like significantly below the Winner's formula calculation? Well, that would be lower than expected CO2, which is respiratory alkalosis. So you could like have a patient who's got DKA, but then they're scared of the hospital and they have a panic attack, and now they're like super hyperventilating in the early stage of DKA. So it's possible that you could have respiratory alkalosis on top of metabolic acidosis, and Winner's formula would tell you that. So it can tell you if your CO2 is too low compared to expected and too high. Classically, the one we're worried about, though, is somebody who's hypoventilating, who's in respiratory failure. That'd be the big one to be concerned about. All right. Any other questions that you see here, Moses?
Just quickly to point out that what to do with an abnormal bicarb or chloride when they don't give you an ABG. Here's where I think taking the full vignette into context is really important. So let's imagine that you got that DKA question, but they didn't give you the ABG. If they just give you the Chem 7 and you see a low bicarb and a diagnosis of DKA, you should operate under the assumption that you're dealing with an anion gap metabolic acidosis. So it's tough to make generalizations about abnormal lab values divorced from the clinical vignette. But if your clinical suspicion is high for an acid-based problem from the vignette, but you don't have all of the information, like maybe they don't give you the CO2 or maybe they don't give you the bicarb, you should proceed under the understanding of the physiology of that disorder.
Exactly. And I'll add to that just a little bit by saying that they don't always give you all the laboratory values. And the only laboratory value you get is probably the only abnormal one. If they don't give you a lab value, for all intents and purposes, you cannot consider that to be abnormal. So if they just give you the bicarb and not the CO2, we can't really believe that the CO2 is actually going to be bad in that case. All right. Do you see anything else there, Moses? I think we've mostly covered you guys' questions. If you have any last ones, try to sneak them in real quick because we're about to wrap up here.
I am not seeing anything. With that, just want to wish you all a great evening. Hope this was really useful. There will be more webinars and other resources. Definitely subscribe to the email sort of push notifications. And we hope to see you in subsequent webinars. Give us a call if anything, if we can help you out with anything. And it's been a pleasure, Joe, as always, to chat with you. I learn from you all the time.
And you, Moses. All right. We'll see you guys on the flip side. See you in the next webinar.